All right. Adhesions. I know you guys are prepping for the MRCS, and adhesions are a huge topic.
Yeah, for sure. Can't get around them.
So we are diving deep today, getting to the essentials. You with me?
Absolutely. We'll hit all those must-knows, causes, classifications, how to treat them, how to prevent them, stuff you really got to know.
Perfect. So basic definition first. Adhesions, what are we talking about?
Yeah.
The source says fibrous connective tissue. It's forming between surfaces that should not be stuck together.
Yeah, it's like internal scar tissue, basically. But, and here's the kicker, it's not just a little sticky spot. This stuff can cause serious problems.
Oh, totally. The source mentioned bowel obstructions, pain that just won't quit. Even infertility can be linked back to adhesions.
Precisely. Surgeons got to be on top of this. And get this, the source said something like 60, maybe even 70% of small bowel obstructions in, developed countries. Adhesions.
Whoa, that's a big deal. Okay, so categories then. The source breaks it down, right?
Yeah.
You've got congenital adhesions, the ones you're born with.
Right, but those are less common, like 2% of cases, the source said. Meckel's diverticulum, malrotation, that sort of thing.
So the vast majority, we're talking 98%, those are acquired. Happens after you're born.
Exactly. And a huge chunk of those, ready for this? 80%.
80%. That's got to be from something specific.
Post-operative, meaning after surgery. So as a surgeon, you're kind of part of the problem. Got to be mindful of that.
Wow. And the other 18%, the source said those were post-inflammatory, after things like appendicitis.
Yeah, appendicitis, diverticulitis, inflammatory bowel disease, those kinds of things can trigger adhesions.
Okay, so knowing all this, how do we even treat them? Seems tricky.
It is. Source lays it out nicely, though. Pre-op, it's all about stabilizing the patient. Nasogastric suction, IV fluids. Some people call it drip and suck, but hey, it works.
Right. Got to make sure the patient's strong enough if surgery's on the table.
Exactly. Nutrition is vital too, of course, but sometimes you can't avoid surgery.
So surgically, what can you do?
Bypass, resection, or breaking up the adhesions. That's called adhesiolysis. Pretty delicate procedure. But honestly, the real key, and the source emphasizes this, is preventing adhesions in the first place.
Prevention, that's the gold standard, isn't it?
Yeah.
And the source had some cool techniques, like minimizing how much you handle the bowel.
Yeah, the less you mess with it, the less irritation you cause. And
Yeah.
using these special fluids, they act as barriers, kind of keep the tissues from sticking together while they heal.
It's all about creating the right environment, huh?
Totally. Every little detail matters, even the gloves you use. The source specifically mentioned powder-free gloves.
Why powder-free? I'm curious.
It's about keeping the surgical field as clean as possible. That powder, it can actually trigger inflammation, make adhesions more likely.
Wow, didn't think about that. Okay, so surgery done. What about after? Post-op care, how does that tie in?
It's like an extension of pre-op. Get the patient moving, ASAP. Early mobilization, it helps the bowel wake up and do its thing. Less chance of adhesions forming.
Makes sense. What about feeding? The source was pretty big on enteral feeding.
Right. If you can get nutrients straight into the digestive system, that's the best. Way better than IV feeding, helps with gut motility, supports healing, and that can prevent adhesions.
And antibiotics.
Judicious use, that's what the source stressed. Only if there's a clear sign of infection, otherwise you might be doing more harm than good, disrupting the gut microbiome and all that.
Interesting. So much to consider. Adhesions, they're a tough nut to crack, but understanding the causes, how to treat them, and especially how to prevent them, that's crucial for any future surgeon.
Absolutely. And remember, this was all focused on the bowel, but adhesions can happen anywhere, different organs, different challenges. So much more to learn.
Yeah, that's a great point. All right, future surgeons, good luck on your MRCS. Keep studying, keep asking questions, and you'll be just fine. We're out of time, but keep diving deep into those sources.
You got this.
And we'll catch you next time.